All right, so welcome everyone, and thanks so much for attending. I just wanted to say a few words as an introduction to this seminar, just to kind of place it in context a little bit and to give some background around why it's being hosted by CIDES and the School of Public Health's transformation committees. So, in 2021, Merriam-Webster the word of the year by Merriam-Webster was vaccine. And the word had to be redefined to factor in the novel mechanism with which the mRNA triggers the immune system, but also it's been the cause of intense debate about human rights and personal choice, political affiliation, health inequality, and so much more. In our communities, it has been a divisive issue. It has polarized families, contributed to conflict and frustration, particularly on the part of public health practitioners who've historically seen the impact of vaccination on infectious diseases. Social media has been such a magnifier and these divisions and attributing hesitancy to the right wing, fundamentalism and ignorance. And so for this reason, the Transformation Committees decided to, as part of their effort to understand and celebrate diversity in our community, decided to host this webinar that would highlight the voices of vaccine hesitant people. So we actually struggled to find people who would agree to come forward on such a platform. But we did still feel that the voices needed to be heard and understood, especially by people involved in the work we are. So I did the next best thing. I called a friend, someone who's heard hundreds of voices in South Africa around their views and around COVID and COVID vaccination. So Dr. Nirvana Pillay is a visiting researcher at the School of Public Health at University of Witwatersrand. She's the director of the Sarunia Public Health Trust. And she's worked as a qualitative researcher and consultant in public health in projects that require interfacing closely with community, government, and civil society. She was a principal investigator on the vaccine study, which is a collaborative study between Sarunia Public Health Trust, the Medical Research Council, and the HSRC. And they explored case studies of vaccine hesitancy and COVID-19 health-seeking behaviors using a socio-ecological model of social and behavioral change. So without further ado, it's such a pleasure to introduce Nirvana. Welcome, Nirvana. The floor is yours. You might want to unmute.
Rookie mistake. Good afternoon, everybody, and thank you, Ushma, for hosting this and for inviting me to speak. I'm speaking about something that I have been involved with now for the last 2 years, and something I'm very passionate about, which is really listening to community voices on diverse public health issues and trying to really understand where people are at in terms of how they understand health messaging, and ways to improve well-being. So the title of this talk is on community voices on the Vinegar, and I'll tell you in a bit why the Vinegar, and exploring COVID-19 vaccine hesitancy at the intersection of the structural and social context in South Africa. So in this presentation, I've really pulled out many quotes, far too many, and typically you wouldn't see a presentation like this, but I really wanted to hone in on the idea of community voices. These voices have to be understood within the broader context of quite a larger mixed method study. And I'll start off by telling you a little bit about the broader study, and then I'll hone in on the particular community voices. So the overall study, as Ushma described, was a collaborative study between a number of partners listed at the bottom. And we looked at case studies of vaccine hesitancy and COVID-19 health-seeking behaviors using a socio-ecological model of social and behavioral change. And we did this through looking at a comprehensive ward-based study so that we could help and support the building of a comprehensive ward-based response to COVID-19 and particularly vaccination as we moved on from the first year in the pandemic to the second year, where the whole question of vaccines became important. So the two main study questions were, firstly, to understand the barriers and challenges to vaccine uptake at a very local level, which in this case was a ward level, and then to understand what the potential strategies were for addressing vaccine hesitancy and improving uptake. And in the talk today, I'm going to focus specifically on the first question, which is really about understanding the barriers and challenges to vaccine uptake. So in terms of the research framing and methods, our broad study aims was to use a socio-ecological model to provide this ward level assessment of the contextual and social factors. And we looked at both enablers and barriers to vaccine acceptance, but also for ongoing adherence to behavioral and NPI measures, given that these have not been dropped even after vaccine implementation. And then we aimed to pilot the World Health Organization Behavior and Social Driver Survey tool to provide guidance on its application in South Africa to baseline vaccine hesitancy at the local level. Now, this tool hadn't been piloted in a low and middle income country yet. And so this provided an opportunity for us to pilot this tool within the study. So apologies for this slide. It's a bit busy and I'm not sure you can see the black and white writing. I tried to start messing with it, but then it started looking ridiculous and I just left it as it was. But basically, just to explain, on the left-hand side is the socio-ecological model, which is the basic model we use, particularly for the qualitative data collection. And it starts from the person, the individual, the self at the center of the circle, and building around that to the partner, family, peers at the interpersonal level, to our leaders and health providers and other service providers at a community and organizational level. And they're more broadly looking at the wider environment like policy, legislation, government, etc. And within that, the cross-cutting factors that inform how individuals believe, when you situate them within this kind of model, is the kind of information they have, the motivation they have to, in terms of their attitudes and beliefs, how that impacts on their ability to act, in other words, their agency, so their skills, their self-efficacy and access, and then the wider social norms within which they lead. And this may be their perceived norms, sociocultural norms, gender norms, etc. And then on the right-hand side, we really have the four domains of inquiry for the behavioral and social drivers of vaccines hesitancy model. And the four domains are really about what individuals think and feel about vaccinations, the social processes that promote or hinder vaccination, the individual motivations or hesitancy to seek vaccination, and then the practical issues to ultimately take us to whether people end up being vaccinated or not. Now, in this case study, we looked at 4 wards across South Africa. It was Rylands in Ward 48 in the Western Cape, Wentworth, which is a community in the south of Durban, in KwaZulu-Natal, Sweetwaters, which is a semi-rural community outside of Pietermaritzburg in KwaZulu-Natal, and then Alexandra, Ward 75, which is an urban informal, well, mixed formal, informal settlement near Sandton in Johannesburg. And in this presentation today, and for the purposes of really focusing on community voices, I'm really going to speak a lot about Alexandra, Ward 75, because this is the study that I was based in and led, and I understand the community and the kind of I was a face-to-face researcher, with informants and focus group discussions. So in terms of research methods, in phase 1, we started with a snapshot of community COVID-19 experience and response. And really, it's within this phase of data collection and the data that we generated in this phase that I want to really concentrate this talk on today. So what I suppose is unique about the study is that before we started asking people about vaccines or moving on to the BESD survey, we started asking them about how they had experienced COVID. In other words, what were the impacts of COVID on them at the different levels of the socio-ecological model, at the individual level, at the community level, at the family level, at the interpersonal level. And we did this through a process of key informant interviews with community stakeholders and a method called expression sessions, which I'll talk a little bit more about in a second. And then we went on then to do more focus group discussions as the vaccine implementation was rolled out. We then did the survey with the BESD tool, and then we went back and did more focus group discussions that focused on vaccine hesitancy. In our final phase of the project, we held local stakeholder engagements. We presented at the ministerial advisory committees. We went back to communities and tried to interface with them around what we had found. So just a quick a summary slide of our respondents. This was in total, we had 1,193 of survey respondents. We spoke to approximately 54 key informants across the 4 sites, and these were community stakeholders, leaders, religious leaders, police, ward councillors, anybody that the community identified was as a key stakeholder in the community. And then focus group discussions were about 200 respondents, and we did these in through expression sessions and then focus groups, and we had these split between 18 to 29 age groups, 30 to 59, and then 60 plus, and we split these by gender. Now, I just want to focus a little bit on the first type of focused group discussion. So those are those that we entered at the beginning of the study in terms of understanding how people had experienced COVID-19. And we used a particular focus group discussion tool or a method here called expression sessions. And expression sessions are an approach to collect verbal, visual, and audio-visual data from participants. It draws on the photo voice methodology, and it's used to encourage active participation and meaningful reflection and engagement with research questions. So rather than a typical focus group, which would have maybe started with, so, what does COVID-19 mean to you, or how were your experiences, or how did you personally experience? What you get people to do is you ask them to bring something to a focus group discussion. And so with photo voice, it used to be mainly photos, but now you ask them to bring anything. So that's something, could be an image, could be a photo, could be a video, could be a song, could be a lyric, could be a poem, could be something they cut from a magazine, could be a drawing. And we particularly, we ask people not to use their own photos or to take photos of people, obviously because of POPI, etc. And we did this through having a brief formative or training session before them, where we prepared them for what would happen in the focus group. And then we used this object or this something that they've brought, and we asked them, what it means to them, why they brought it, why did it reflect the COVID experience for them, etc. And why this was so important was because it takes the pressure off people feeling like they're being interviewed, like they're being questioned, like they have to perform in any particular way, like there's good and bad, and that there's any kind of value judgment in it. And it was a very powerful methodology with younger participants bringing things like videos and poems and music, etc., and older participants being slightly thrown by this exercise and bringing from an orange to a picture, anything that they could think of at the time. So just going back and just taking a step back now in terms of just trying to situate vaccine hesitancy. And there's been a paper already published around our findings from the survey data. I'll put it in the chat later, the link to the paper. And I just want to draw your attention here to some of the things that we found around vaccine hesitancy. So just using the definition of vaccine hesitancy as the intention to refuse or uncertainty whether to accept COVID-19 vaccination. I think there's a wide literature on how and why vaccine hesitancy is complex and context specific and differs across time, place, and type of vaccines. And I've highlighted context specific because that's where we're focusing on. And in our general survey data, we had found that 32% of our respondents were hesitant to receive the vaccine once available, and that more than half of these were young adults between 18 and 34. High proportion of them were colored or Black African, very high proportion were unemployed, and with low or no monthly income. And with a focus on those over 55 years, because when this survey was done, which was in June and July last year, was really when we were implementing the vaccine rollout for the older population group, we found that 20% were hesitant to receive the COVID vaccine, and mainly these were from Alexandra and Wentworth, among colored females, low, no monthly income, concerns about side effects, and those who are worried that they cannot access the government online EVDS platform. And I'm not going to discuss this in any detail, but I just wanted you to kind of see what the broad headlines were. And then when you look back at how COVID had been experienced and what the ideas were around vaccine hesitancy, it gives you a lens, not necessarily a clear association, but certainly a lens into how we can better understand this. So, how had communities experienced COVID-19? And we started with understanding how they had actually experienced COVID-19 themselves. And as I've said, I'm looking at a snapshot of Alexandra because I'm familiar with it, and it just it provides such a rich picture. So for those of you who know Alexandra Township at all, it's densely populated. It has high levels of crime and unemployment, low levels of service delivery. It has a very migrant population. It was a small township initially established in the early 1900s, which has grown and grown and grown and has never quite had the space to manage the vast influx of local and foreign migrants. High levels of xenophobia at the site of much xenophobic violence in the last 10 years, including Operation Dudula right now. High levels of substance use, social contestation, but simultaneously it's also a vibrant space. Young people enjoy it. It's enjoyed by many in the community. It's fraught at many levels, but also very vibrant and exciting. And I've just put in two quotes here that really paint the picture. One about housing and two about service delivery. So the first one is you'll find there are 13 in a room, 13 or 14 in a room. That this is what happens with an ordinary house in Alex, and this is a true story. These houses started off as 6-roomed houses. They were big houses. My grandparents used to stay there, and then, due to population explosion, suddenly one uncle has cut this so that he can go to the other side, and another uncle would cut that, and ultimately there was no floor on the floor level, so they went up, and then there was no space, and then they had to go towards the pavement, and that's literally how Alex is. It's literally exploding with people. And then another comment about rats. Alex is also well known for an unmanaged and unmanageable rat population. It's always a health service issue. It's an issue with waste removal. It plagues our healthcare centers, etc. there. And there's just a quote there about taking Tokyo Sequala and others to come and, those in Sandton, the white people in Sandton that want to come and help us, to actually take them away for a weekend, to just ask them to sacrifice one day and come and sleep in these shacks. So a real sense that people don't really have any sense of how people really, really live on a day-to-day basis. And then just in summary of what people had to say about their fear of COVID-19 in terms of the consequences of both COVID as an illness and the associated lockdown restrictions. They were afraid of getting sick. They were afraid of poverty and not being able to put food on the table, of going to hospital, of the soldiers and the authorities. I'm not sure if any of you remember but Alex was one of the sites where the South African National Defence Force really had a very heavy hand in how they treated people. Lots of people talked about it being reminiscent of apartheid style military action and having the same kind of fear as Black people living in Alex. Street traders were harassed. Young people feared for their futures. Caregivers were afraid of how to look after people who were ill. Fear of job loss, and generally fears of, reflections about loss of income, loss of jobs, loss of family, and loss of opportunities. And then specifically their fear with regard to illness and death. We fear dying of COVID-19. And then again, we fear dying of COVID-19, and we fear being beaten up till death by the policemen or soldiers. It's bad. I think they're scared they would be quarantined, or they're scared that they would never be able to talk about to other people. So, the fear of not being able to move around, to hustle, which is what people typically do in Alex because of the high rates of unemployment, or of being able to access their work in the suburbs, or fear of passing COVID on. And the kind of stigma that was associated with COVID-19 fear, that people spoke about the secrecy surrounding COVID that makes people deny its existence, like they won't tell us if they've been infected with COVID. Also, some families won't say that COVID was the cause of death of their loved ones. And then the next quote, I'm just highlighting one bit here, but the fact that if a person has died from COVID, the coffin will be wrapped tightly, no one ever gets to see it, is certainly a dead giveaway. That is how you can tell whether the death is COVID-19 related or not. And then the last quote is actually it was actually a key informant interview, but with a group of people, community health workers, who say, some say you are bringing this disease to us here, and now you do not understand anymore where this thing is going. You are wearing this T-shirt of theirs, so it's better if you are dressed like this because they do not see you. And here what they're alluding to is that as community health workers, they experience the same kind of stigma that they experienced during the HIV days, the early days of HIV, where now wearing the T-shirt gave them a sense that they were, they were target of community scorn. General feelings of loss of hope, difficult to stay positive, loss of hope about the government having bought expired vaccines, loss of hope if well-educated individuals and elites go and purchase vaccines that are expiring. What hope can ordinary community members have? And then just hope that all the things that were promised to people before COVID that was snatched away, which is really what the last quote speaks to. So looking at these experiences of COVID-19, what did it contribute to vaccine hesitancy? So people felt that there was, if you put it together, that there was no clear voice from the community and government leaders. So, the quote that it's not so much that they fear COVID, but that there's been so much false information and that we end up not knowing what or who to trust. So there's no direction. And then a quote here, I think our government needs to come and educate people about the benefits of taking the vaccine. Health officials need to come to the hostels. Alex is a place that still has a lot of the remnant worker hostels. So come and educate people about COVID-19 and why it's important to vaccinate. People here still don't believe. Lots of lack of trust in vaccines. So people feared that they're not getting the good quality vaccines, that poor people won't get the good quality vaccines. A sense that the government sees people as not important. So we may be vaccinated with that Johnson & Johnson because we are desperate sheep. The government will come and play us. So a real sense of a lack of trust of the government. I hope we also receive the same quality vaccine as the president and essential workers. I would not go for the vaccine if I learned that the ones given to us are not the same, are not the Johnson & Johnson or the other good quality ones. And then a quote here about a senior citizen who asked the healthcare workers about whether she was receiving the Johnson & Johnson's ones, which had been expired. And the nurse, getting irritable and saying, you're asking us a question that we don't want to answer in such a public space, so we'll answer the questions privately. So a sense that there's something to hide. More about vaccines. This thing is still going to have its own politics, which pharmaceutical companies are going to get the biggest chunk of money to vaccinate. Now we have J&J, and of which Johnson & Johnson is an American company, and then others would be like, this is good quality stuff. You cannot expect a white man from Santon to take a vaccine from India. You don't expect a white man from Bryanston or Houghton to take a vaccine from Russia. They will always take something from Oxford. England or America, and then the one that is called AstraZeneca, take that one to the people in Africa, you see. It's a real sense of people, experiencing the hierarchies in South African society and believing that they'll be victims of it. And then another quote, which is where the vinegar comes from, and I have a problem with it as well. Why did the Pfizer vaccine come here in the cover of darkness? The vinegar did arrive here in the cover of darkness too. The sense that they didn't trust, because they're first starting with the vinegar, and then it's the Johnson & Johnson, and a quote here at the end which refers to the Pfizer vaccine as this Johnny-come-lately Pfizer vaccine. So I think what these quotes say is that people really were following what was going on in the news. They had a sense of what was going on. They lacked faith. They were listening to what people were talking about. You'll see now in terms of side effects and blood clots. They were listening to what, in terms of the procurement and expired vaccines, etc. And it was a broader sense of how, in general, people are not taken seriously, I think, by government or in the health system. And then the fear of vaccine side effects. People that are sick, afraid that, my health is already not good. I'm a weak person health-wise, and I fear becoming even more sick or possibly dying. I'm truly scared that the vaccine may finish me off. I'm afraid, I'm concerned about side effects in the long run, because nobody knows what's going to happen in the long run. And then no one is educated about the vaccine, the side effects after the vaccine. So people are skeptical about the vaccine. And then people also spoke a lot about the logistic and practical barriers to vaccines, waiting at vaccination queues, in the cold, elderly people not being able to walk long distances, transport money. And the last quote there, talks about people waiting in long queues, about the hunger during that time where people were just reliant on the grants and people weren't working. And the idea that, you needed to have some food, or that people should be given fruit at the vaccine queues, etc. And given that these were in the early days of the vaccine rollout, a lot of these things have already been addressed in some of the sites, etc. So in more or less towards conclusion, how did our understanding of community experiences of COVID-19 help us understand vaccine hesitancy better? At a broader level, we see that people wanted to return to normal, that lives had been terribly impacted, and this provided an opportunity for vaccine uptake. That the three main barriers to vaccine uptake were vaccine literacy, the agency of individuals and communities, which was very much linked to how they had experienced COVID-19, and then logistics, as just discussed. And most importantly, that the solutions to vaccine uptake are predominantly local. In other words, they lie in the social and the structural context in which people live and work. And so the three main barriers are described here. And just in terms of the question of agency, we find that community and agency had been compromised, economic collapse, high levels of food insecurity, high levels of employment precarity, and a massive reliance on the social relief of distress grant. Increase in fear of jobs, increase in COVID stigma, loss of hope, especially for young people in the country, And then, the absence of community leaders and an authoritative voice on COVID-19 and COVID-19 vaccines. And the data that I've added here around food insecurity was drawn from our survey data. And the gaps in vaccine literacy, I've just given you a brief breakdown that really there are 3 levels of vaccine of any kind of health literacy. That's your basic and functional literacy. That's just knowing basic information, which is, I suppose, what you'd expect in your first year of implementation. And then there's the higher levels of health literacy around communication and interaction, and then your critical engagement with health literacy. And so the gaps in the early years were, well, in the first year, it's still the early years, were really about the basic medical facts, the fear of vaccine side effects, and about countering the myths and the misinformation that was circulating and is still circulating around vaccines. So just in terms of pulling this all together, my concluding thought was that if I had to present the data, or we had to look at the data from the Wentworth scene, the Islands team site, or the Sweetwater site, we would find that their vaccine beliefs was similarly situated in how they had experienced COVID-19, which in turn is impacted by their local context, by the socio-demographic profile, by the history of the community, and by lived experience. And that at the end of the day, it's context that matters. So a one-size-fits-all approach doesn't work. But of course, as scientists, as social scientists, as behavioral scientists, as health practitioners, it leaves us with many unanswered questions and many thoughts about what we do about this. And I suppose the provocations I leave you with is, how do we communicate with integrity, given that as scientists and health practitioners, we have little control of government level mistrust and the general anxiety in South Africa related to this kind of things communities spoke about, which is really poverty, unemployment, and economic and food precarity. So I guess that's the wicked problem of the kind of social determinants of health approach. And then how do we communicate public health messages to keep pace with rapidly developing science and evidence, so we remain integrous to the populations we represent? And I think that's me. Thank you.
Thanks so much, Nirvana. That was great. We're seeing a lot of applause coming through. I concur. I'm struggling a little bit to be able to see hands up and participants for some reason. So I don't know if you can see the participants, Nirvana, but I apologize. I was wanting to help, but very happy to take questions and comments from the floor. I just might not see it myself. So can you see that?
I'll check.
Thank you. Thanks, Simpiwe.
It's Itani.
Oh, sorry. It's Itani, sorry. Me too.
Nothing yet?
I'm intrigued that Simpiwe is not in the room, but he's coming anyway.
So he links himself.
He's linked in. Anyway, we're in the room and I can see, so I can also help with looking at
Thanks, Marianne.
There isn't anything yet, and I just want to, but I've got a question. So first, sorry, there's a bit of an echo.
Just switch off the mic. On the.
Is that better? I think so.
Yes.
So thanks very much for an excellent presentation. The one question I have is kind of quite specific. Some of our health workers, just to introduce myself to Nirvana, Marianne Davies, public health medicine specialist in the Western Cape. The one thing, and I was interested how many of the comments related to kind of vaccine branding and a sense that, we're just getting given whatever we get given. and we must accept that. And just to reflect that one of the comments that the people running the vaccine programs and at the coalface in the Western Cape said that they found it much easier to persuade hesitant people to take the vaccine if they could offer them choice. So in other words, if they could say, we've got J&J and we've got Pfizer, and which one would you like? And for many sites, that wasn't the case. You got whatever you got at the site. And for a long time, there actually was no choice at all. And so I'm wondering, both in this sphere, but in healthcare more generally, and particularly, you know, we've had such a strong public health approach to so many things, which is pragmatic, to say you must get this because this is the one on the EML and this is the only one available. But to what extent people have felt like, you know, because we're poor, we're given the cheap drugs in Africa and we don't have choice, and how important you felt that was. And then I'm also just really interested to hear about your thoughts about that second question of yours, as someone who's had to spend a lot of time trying to communicate public health messages and the challenges. And I mean, I think one of our biggest challenges with vaccines was that everyone thought this was going to be the panacea. It was going to stop all infections. And, you know, we'd all get vaccinated and COVID would go away. And the disillusionment when that turned out not to be the case, I think probably contributed a lot to hesitancy. So that's my comment. I see Mondi also had a question, but perhaps take your responses first and then go to Mondi.
I'll try. I mean, I think you're absolutely right that people have a sense that, you know, that choice means greater agency. It means that people are taken seriously, that as I've described, people already, you know, as things were coming out, as there was talk of vaccines being developed in India and Russia, etc., communities understood that. They may not have known all the details, but they certainly understood that. And so I think choice means that you're giving people agency. And at that time, when we collected data, there was no choice. It was just very early on, and it was just being rolled out, I think, mainly to the older group. And I think, you know, so I do think that matters, because there was a sense that, you know, who you are in society affects what you get, and a general feeling of being let down in these communities means that people believe that they get the worst of everything. So just to agree with you that I think the choice matters. The second question about how we communicate these messages, you know, with integrity, I don't know. I mean, I think it's to communicate as openly as possible, to communicate as often as possible, to try. And I think that you know, there's a lot of space for social media to also be flooded with the kind of right, I don't want to say right messages, that sounds wrong in the sense too, but with accurate messages, with what we know as it presents itself. Because we, you know, people also said things like that, well, you've got to take a vaccine, but then you've got to still wear a mask. And that's a very difficult thing. That's a little bit like it used to remind me of the male circumcision HIV messaging. You know, these are difficult things for people to completely understand, and not incorrectly so. So I don't know whether there's a right or a wrong way, just a sense that one just should always try and communicate as honestly as possible. And I don't know whether, I just wanted to get to Diane's question in the chat about the meaning of vinegar. I think it just became like a community speak for AstraZeneca. I don't know, like we noticed that it would be AstraZeneca, and then it was the vinegar. And then people started talking about the vinegar. So I think it became, particularly in Alex, that is, a kind of shorthand for what people saw at the beginning to be, you know, something they weren't quite sure about. Sour, leaves a particular taste. I don't know. I mean, I may be reading a whole lot into it, but that's how they spoke about it.
That's fascinating. And I mean, I guess another related question is, I think in February 2021, having just got through the second wave, is everyone was desperate. If they could have got themselves a vaccine in February 2021, whether it was the Vinegar, AstraZeneca, or something else, people would have probably lined up in their masses to get it. But the extent to which the delay and also the sending away of AstraZeneca sort of cast doubt in people's minds about, the value of vaccines. There's a question from Tumelo in the chat. Tumelo, I don't know if you want to unmute and ask your question.
Thank you very much, and thank you for the presentation. So we are busy, I'm from UCT, and we're busy with the study on vaccine hesitancy as well in the Cape Flats. So my question is, one of the things that we found was a factor in vaccine hesitancy was religion. So people were talking about the beast, things like that, referencing the Revelations chapter in the Bible. Was that a factor in your study, religion?
Yeah, we also got that in the study. There's a very rich data set across these 4 sites. And it was religion. People were being injected, that there was going to be some kind of chip, that it was a devil. It was a way of taking out the African population. And yes, so yeah, there was religion as well that also played a role.
Thanks. Mondi, you had your hand raised earlier, but I can't see.
I chickened out, but I'll go anyway. Thanks, Miriam.
Please go ahead.
Dr. Pillay, thank you so much. That was a really rich presentation. Especially appreciative that you just focused on the social cultural context so much. So I suppose my most recent background is one of clinical trials for medicines and vaccines, not specifically for COVID. So there was quite a lot of overlap with what you described in your focus groups and initial sessions with community leaders, in terms of community engagement. But I think what's always struck me is that perhaps in that sort of trial setting, which might be slightly different, is that we really focused on the research literacy part rather than the health literacy part. And I can't help but think that it's actually done us a disservice. And so I know that you mentioned focusing on vaccine literacy, but I maybe want to ask, in terms of just general health literacy, how good do you think that is across groups that you surveyed? Is that a specific need? And then also maybe just out of interest, when you did meet focus groups and get these opinions, did you actually intervene at any level, or did you merely record the opinions? I'd be really interested to know how you managed to hold yourself back from actually intervening. And then maybe just the last part to a very long question. You mentioned phase 3 of your study design, interacting with stakeholders, and I'd just be interested to know how that's going, and if there are any concrete plans out of that. Thank you very much.
I'll try. Are you asking just about health literacy more broadly?
No, so I'm maybe saying that in interventions that has maybe had the opportunity to have focus groups in the past, have we focused on the right things? And in focusing on vaccine hesitancy and vaccine literacy, are we focusing on the right thing? Or is there actually a bigger discussion about health literacy, which ties into the agency discussion, perhaps?
So I think, I'm not sure if I'm understanding you correctly, but I suppose that on the one level, you can use a focus group discussion to understand people's perspectives, so what they understand about vaccines or HIV or whatever your issue, whatever it may be, high blood pressure, etc. But then I guess you can also use them as a point of education, where you could, I suppose, teach people through or help people with the information, or give people basic information through smaller groups. I mean, I think here we're talking about focus groups specifically to ask people about what they think. And in terms of non-intervening, we don't intervene. We never step in and say that's right or that's wrong or whatever. Our role, in that is to understand people's kind of subjective experiences as best as we can, and to give them the space to feel comfortable to express that. Kind of really separating the issues. Usually there'll be a participant information sheet and information about where people can get other information, or in this case, when we did the survey, we'd have things about the vaccine sites or where you'd get information. But in the actual research space, we certainly never corrected anything that we heard about people, unless people came to us afterwards or approached us through any of the contact details provided. In terms of our stakeholder feedback, going back to it, it's, we were trying to do an action research, which was really to identify with communities and then go back to communities. We did better in some areas than in others. So some areas were, like in Alex, for example, the kind of the power dynamic and the kind of where the power lies with the main stakeholders in order to give those feedbacks are slightly more complicated, and it takes longer, and it means going through the ward council, etc. In other communities where it was directly, it was more mediated by the community, people did things like presented things on Facebook and put up presentations on Facebook and distributed it more widely. So it differed from site to site. In the Sweetwater site, there's an established research site by the HSRC, so they're also able to do some of that community feedback more effectively. Yeah, so it varied across our sites, and it's ongoing. I mean, I think with all this work that we do try to keep the initial stakeholders. We look to get support when we're going into the community, kind of in the loop along as the study progresses and stops, etc. I don't know if I've answered your question, and you're welcome to reach out. I'll put my email addresses there as well.
Thank you very much. Thank you.
Thanks so much. We'll go to Virginia.
Thanks for a fantastic presentation. I was so interested in the experiences of COVID and how they shaped, how you saw that, how they shaped people's vaccine hesitancy. And I'm just curious about that, why, and I put it in the chat briefly, is why you think that the negative experiences, particularly from the state and stigma and all of those things, trumped any kind of sense of that people believe that they could overcome COVID by taking a vaccine? Is it because people's lives are so overwhelmingly difficult, and they see that everything as perhaps hostile, and therefore seeing an intervention like this has also been perhaps a hostile thing that might be intervening in their lives? I would have thought that perhaps people who've had experiences of death due to COVID might be much more interested in finding a solution and embracing a solution than rather seeing a purported solution as being another hostile thing. And so, does that relate? What do you think of what I said? Thanks.
So, if I understand correctly, I mean, I do see what you're saying. I think that, and here, I mean, this is just my sense of what I get, what I think I understand from communities, is that people's general lives are really, really hard, and their experiences, take all health issues aside, just in the daily living, putting food on the table, having work, high rates of unemployment, trump everything else that we may possibly see as the worst thing that can be brought on by a pandemic. So in some ways, COVID illness and health-related stuff sometimes didn't feature hugely with what people spoke about. They only spoke about really the fact that they couldn't hustle, that they couldn't get short-term work, that they couldn't get into the suburbs to complete their work, that they were stigmatized because they couldn't, some of the domestic, Alex has a lot of domestic workers who service the nearby community, so employers always wanted to see a test. So it's this balance I think people are constantly making between life and between what, I suppose particularly for us in public health think is like the worst thing that can happen. So sure, for people who had the direct experience of losing a loved one, an older person or someone to COVID, it I think it changed things. And I think older people were more scared and were more willing to be vaccinated, etc. With younger people, there's just a general sense of hopelessness. And I suppose once you've seen after the first wave, we were okay, and then the second wave we were okay, and then the third wave, well, along came vaccines, but we seem to have survived it in the first two waves, and we remain unemployed, and we still don't have school, and school hasn't gone back to normal. It kind of just isn't that big, or the health stuff isn't that big. I don't know whether I'm making sense. And this is more my, my opinion, I think.
Yeah, it's quite remarkable, though. Yeah.
Thanks. I see Sue Cleary has just written in the chat that there was also, and in part due to the delay, there was the opportunity for there to be the importing of anti-vax ideas, and I think sort of reworking into our own understanding from other countries, partly due to the delay, because there was the time for all these ideas to develop and then reach us before the vaccine program actually went at full speed.
And I think that, of course, that's even, that continues even today as we go on from wave to wave, and people see, you're vaccinated and you get all the stuff that doesn't necessarily make sense for people, like at a level which, well, I've now seen so many people get COVID and they survived, and we're in the fifth wave, and now it's, you're still wearing masks, whatever. It's all the kind of confusing messages that are coming at people. With the more delays there are, the more confused it becomes.
Plenty of confusion around, I think. From my side, as SIDA Director, I want to say a huge thank you. This has been an excellent presentation, and thanks everybody who's attended and contributed to the discussion. And I'm going to hand it back to Ushma to close.
Thanks, Marianne, and thanks so much, Nirvana. I think listening to your talk reminds me of a talk I attended about how children see medicines when they're sick, and when you ask a child to draw draw their experience, the medicine is really just a small little thing in this bed, and the caring mum looms largely over the child, and it's that experience of feeling cared for and supported that really people are looking for. That, for me, that was kind of a big take-home message. And we look so largely at, or when all you have is a hammer, everything you see is a nail, in the sense that we really focus so much on the technology that the context really is so powerful in terms of how people make these heuristics. So thank you so much for such a rich discussion and talk. And I'm sure we'll take it offline again afterwards. But and thanks everyone for the great turnout. Really appreciate it. And hopefully the SIDA and the School of Public Health Transformation Committee will have more provocative webinar seminars in the year to come. Thanks everyone, and bye.